Assalamualaikum. Today we are going to discuss incontinence of urine in men. And the main objective of today's presentation is epidemiology of the incontinence and the impact of quality of life, the risk factors associated with incontinence, physiology of maturation, approach to a patient with incontinence, types of incontinence, pathophysiology of different types, and management. About 8.2% of 4.2 billion world population experience urinary incontinence. In men, the prevalence of incontinence is much lower than in women. About 3 to 11% of total patients in urology OPD present with incontinence. Urge incontinence accounts for 40 to 80% of all male patients. Stress incontinence accounts for less than 10%. Incontinence in men increases with age as in women and men both, but in severe incontinence in 70 to 80-year-old men is about half of that in women. Incontinence have a major effect on quality of life. It imposes a significant psychosocial impact on individuals, their families, and caregivers. It results in loss of self-esteem and decrease in ability to maintain an independent lifestyle. Increases the as incontinence worsen, the caregiver's activities of daily life independence increases. And at the consequently, the patient have decreased social interaction with friends and family, and the sexual activity may be restricted or avoided entirely. These are some of the risk factors, which includes immobility, chronic degenerative diseases, impaired cognition, medications, morbid obesity, diuretic, smoking, constipation and fecal infection, delirium, environmental barriers, diabetes, stroke, and use of excessive caffeine. Now we will discuss the physiology of maturation. The maturation depends upon three model of three nervous system: the somatic, parasympathetic, and sympathetic nervous system. As the urine fills the bladder, the uterus stretches and allows the bladder to expand. 300 ml is the threshold at which the bladder brain recognizes the bladder for test. Lower bladder at lower volumes of the bladder, sympathetic nervous system is stimulated and parasympathetic is inhibited. As the bladder fills, the parasympathetic nervous stimulated and it contracts the bladder, and the sympathetic nervous system inhibited, which relaxes the internal sphincter and patient urinates. The intravesical pressure, which increases the resistance within the urethra, and the urine flows out smoothly. The pudendal nerve innervates external sphincter, which is skeletal sphincter.
Skeletal muscle.
Skeletal muscle. Autonomic receptors present in the bladder and the sphincters, as shown in the picture. And the parasympathetic, while the pelvic nerve innervates most of the wall of present in the wall of the bladder. Hypogastric, which is sympathetic nervous system, have nerve supply to the internal sphincter, and the pudendal nerve, which is spheric, supplies the external sphincter.
What is this ACH?
So it is pre-synaptic acetylcholine.
Yes. So it denotes acetylcholine.
Yes. Now we will discuss the basic definition of urinary incontinence. International Continence Society defines urinary incontinence as the complaint of an involuntary loss of urine. The urinary functionally has two parts: urinary bladder reservoir and bladder outlet sphincter magnet. The incontinence occurs when both of the parts are malfunctioning or either of the parts is malfunctioning. Approach to the patient with incontinence. Every approach to the patient starts with history. These are the 2 points which should be asked in the history. And it starts with the degree of leakage. Leakage is relation to activity, position, and state of bladder fullness. Time of onset and progression of incontinence, previous history of prostatic or pelvic surgery, and the use of drugs and dietary habits, systemic disease such as diabetes. And patient may be asked to maintain a menstruation diary in which the time of menstruation, body volume, and type of incontinence can be mentioned. Examination, in general physical examination, we should look for anemia and generalized body and suggest for underlying malignancy or sign of renal impairment. In abdomen, the pelvic fracture can be suggesting of urinary retention causing overflowing incontinence. Pelvic mass should be looked for, and loin fullness due to hydronephrotic kidneys. Digital examination is important in male patients to assess the size of the prostate, its consistency, south and anal tenderness. And then anal tone, the sphincter tone, and the pelvic floor muscle tone. Neurological examination is required if the neuropathic bladder is suspected. Now comes to the baseline investigation. The baseline investigations have two parts, laboratorial and radiological. These are the baseline investigation which includes the laboratorial urine DR, CS, and blood. If in blood we can go for blood urine nitrogen and arteries if renal compromise is in the mind. Radiological examination investigations includes first step is ultrasonography, in which as it is readily available and it is free, cheaper, and it is treated as a baseline investigation. And it includes in which we can see the better neck turning. Post-viral residual volume more than 50 ml is significant, and we can look for the prostate and the consequences of the previous surgery. It's important to note that in men, the incontinence following pelvic surgery, pelvic radiotherapy, and severe symptoms, and other complex underlying pathologies is less likely to respond to conservative measurements and need further advanced investigation. The aim of advanced investigation should be an anatomic abnormality at this extent, assess the activity of the sphincteric mechanism. These are the some of the advanced investigation which includes hysteroscopy and to look for the absence of posterior urethral at critical angle. Hysteroscopy in which the bladder and its neck and the urethral lesion can be visualized. Urodynamic studies include cystometry, urethral profiling, uroflowmetry, and electromyography. Now we'll briefly list the types of incontinence. The stress urinary incontinence, urgency incontinence, overflow incontinence, mixed incontinence, neuropathic incontinence, and post-maturation period. This is the diagrammatic or pictorial explanation of the types of incontinence. In stress incontinence, it is due to increased abdominal pressure and under stress due to the weak pelvic floor muscle, the continence occurs. In urge continence, due to involuntary contraction of the bladder muscles, and overflow continence due to blockage of the urethra, and neurogenic incontinence due to impaired function of the nervous system. Treatment options we have three categories, which includes behavioral, pharmacological, and surgical. Now we'll discuss briefly the types of incontinence and their measurements. International Committee of International Incontinence Society defines stress incontinence as involuntary urinary leakage on effort or exertion, or on sneezing or coughing. The two anatomical deficits are the basic pathophysiological aspects of stress incontinence, which include the hypermobility of the sphincteric unit, which is mostly present in female patients due to lax pelvic floor. The mobility of the sphincteric unit is more present. And the second is the intrinsic sphincter deficiency, which is present more in male patients. In men, the stress incontinence causes mostly after post-surgical, and the surgeries include post-prostatectomy, such as transurethral resection of gland disease, radical prostatectomy for prostate cancer, and this occurs due to damage to the internal urinary sphincters and opening of the bladder gland. Post-pelvic surgery due to radical cystectomy or anorectal resection, nerve injury leading to atomic bladder and sphincter weakness. And after the pelvic radiate therapy, such as small capacity bladder radiation cystitis, urinary sphincter damage, bladder neck infection. And diagnosis again starts with the history and examination, then the baseline investigation, which as discussed before. In ultrasound, bladder neck turning and the post-part residual urine is important, and we can look for previous prostate surgery and cystouroscopy, in which the bladder, its neck, and urethral lesion can be visualized. For mild to moderate incontinence, behavioral treatment can be advised. It is renewed, and it includes routine and scheduled auditing, habit training, and promoted body, bladder retaining, pelvic muscle rehabilitation, such as pelvic muscle exercises. This is table which outlines the other managements of stress incontinence, which includes periurethral bulking agents. It is a temporary solution only mild and moderate following prostatectomy. The slings can be used predetermined. There can be two fixed and adjustable. And the gold standard is artificial urinary sphincter, which is for moderate to severe stress incontinence. The bulking agents include hyaluronic acid, dextra, normal gel, and recently the myoblast, fibroblastic adults stem cells have been injected in the periurethral tissue with promising results. These cells stimulate the local tissue proliferation, smooth muscle, and collagen and elastic fiber, and thus improve the competency of the sphincter. Artificial urinary sphincter. It is the most commonly implanted sphincter, such as AMS 800TM. It is a device comprising of three components: a cup and position around the bulbar urethra, a pump implanted into a subcutaneous Dardos pouch in the scrotum, a reservoir balloon placed extraperitoneal in the groin. The principle of artificial urinary sphincter is fluid from the reservoir is filling the cup, transmitting an exclusive pressure onto the urethra. Squeezing the pump shifts fluid from the cup into the reservoir, therefore opening the cup, allowing the unobstructed body. This is the picture showing the artificial urinary sphincter, in which we can see the exclusive cup being placed on the bulbar urethra. These two are the connectors. This is the pressure balloon or the reservoir, and the control pump. Urge incontinence. The inability to hold the urine following a strong, sudden, and desired void. It is due to the reduced bladder compliance and the result of overactivity. International Incontinence Society defines overactive bladder as symptoms of urinary urgency, frequency, and nocturia with or without urinary incontinence. Neurogenic, myogenic, or urethral bladder dysfunction can lead to urge incontinence and the constellation of symptoms that define overactive bladder. Pathophysiology of urge incontinence includes associated storage symptoms such as frequency, urgency, and nocturia. And the pathophysiology behind is the bladder outflow obstruction, idiopathic dysphagia, or overactivity and secondary to bladder pathology such as infection, cancer, and stones. Urge incontinence can be associated with hematuria, dysuria, pain, and recurrent infections, and the underlying pathophysiology remains the same: infection, cancer, stone. It can also occur following the pelvic radiotherapy, which causes radiation cystitis, urinary sphincter damage, and bladder infection. Neurological conditions such as spina bifida, spinal cord injury, stroke, Parkinson's, and diabetes can cause urge incontinence as they cause neuropathic bladder, which can cause overactive or underactive bladder and the overactive and underactive sphincters. Diagnosing starts with the history examination, stress incontinence test, urinary analysis, and ultrasonography. The treatment includes lifestyle modification, which includes fluid management and bladder training as discussed before, which includes pelvic muscle training, scheduled voiding, and relaxation. Pharmacologically, few drugs have been used. The first line drug for urgent incontinence is anticholinergic agents, such as oxybutylin, tortridine, fesotridine, and proxine. They suppress the involuntary bladder contraction and thus reduce the symptoms of overactive bladder. Selective M3 receptors such as receptor antagonists such as solifenacin and derifenacin are the new drugs which are being used. If the alpha blockers and alpha translation inhibitors are added into the treatment regimen, if there is increase in size or pathology related to the prostate. This is again the pictorial diagram which shows the different receptors present in the bladder and the urethra, on which these drugs act, such as M3 acts on the bladder muscle, and alpha drugs on the prostate and prostate. And in use of intravesical botulinum toxin has shown significant benefits in urge incontinence, overactive bladder, and prostate enlargement. It is an important alternative to long-term oral pharmacotherapy. Current trials on seeing toxin and capsaicin and sector nerve stimulation are being done. This is just for a few seconds to relax.
Right.
Now the third type of overflow incontinence is the involuntary loss of urine associated with bladder over distension. The two primary causes, underlying causes are urine retention caused by bladder outflow obstruction, inadequate bladder contractions. The outflow obstruction, bladder outflow obstruction can be due to benign prostatic hyperplasia, bladder neck contracture, urethral stricture, and prostateness. Decrease in retroducer contractility can be due to spinal and peritoneal injuries, over distension, and diabetic cystopathy, in which the sensory and motor functions both are compromised. Diagnosis starts with history and examination specific to overflow incontinence or overflow bladder. is a post-void residual urine which can be detected on ultrasound or with urethral catheterization. It is normally less than 50 ml is normal. The residual volume more than 200 ml indicate overflow pressure. Urodynamic study, including cystoluroscopy, can be used to rule out the cause and differentiating it from other types. Management of the bladder outflow obstruction. Management of the outflow incontinence, overflow incontinence is dependent on again the type of its type. The outflow obstruction root restriction and time body can be advised. The pharmacotherapy includes alpha antagonist and 5-alpha reductase inhibitors. As the prostate and is obstructing the outlet of the bladder, stricture of the prostate and prostate obstruction can be cured with surgical options such as transurethral section of prostate, incision of the bladder neck, and visual internal urethra. And the second type, underactive diffusion, can be managed by bladder decompression with indwelling catheter or de-intermittent catheterization for 7 to 14 days, and along with address to the potential reversible causes, which includes medication, and infection, and constipation. Alpha blockers can be used if the warning trials deliberately fail. But the intermittent catheterization is the treatment choice versus a permanent indwelling catheter. Mixed urinary incontinence is an involuntary leakage of urine associated with urgency and also with exertion, effort, sneezing, and coughing. It is more common in women and elderly, but new studies shows that it has more than 50% predominance, and includes both of the stress incontinence and the urgency incontinence. The presence of urge incontinence and components of overactive bladder are present, such as frequency and urgency. The pathophysiology behind this mixed incontinence is that a reflex response is initiated by urine leaching to proximal urethra during stressful events. Approach again includes, in approach with the diagnostic approach is same as stress incontinence, which again starts from laboratory, radiological, and cystoluroscopy. The management of mixed incontinence is to determine the bothersome symptoms and treat them first. If both of the incontinence as stress and urge incontinence are both equally bothersome, then manage the urge incontinence first. Initial treatment as in urge incontinence is antimuscarinic agents, and then the surgical, and the results for pure stress incontinence remains superior. Neuropathic incontinence. As the maturation is controlled by brain, spinal cord, and peripheral nerve, any condition or disease which can affect the functional structure of the it can affect with the bladder and sphincter and synergetic action of two structures. We will briefly discuss the lesions of maturation pathway. First was the uninhibited bladder. Lesions above the pontine maturation segment, such as stroke and brain tumors, cause uninhibited bladder. Upper motor neuron bladder lesion between the pontine maturation segment and the sacrospinal cord. Examples such as an traumatic spinal cord injury or multiple sclerosis involving cervicothoracic spinal cord. Mixed type A bladder sacral cord lesion that damage the retrocell nucleus but spare pudendal nucleus. It has been highlighted red because it causes the urinary retention. Mixed type A B cutter. In this, the sacral cord lesion gets spared to the nucleus but damage the pudendal nucleus. Lower motor neuron bladder from sacral cord and sacral nerve root regions. These are the 5 lesions of maturation pathway. The lesion related to incontinence include the uninhibited bladder, in which the urinary incontinence may occur with any lesion appearing above the contamination center, especially if the bilateral lesions are involved. In upper motor neuron lesion, the neurogenic bladder dysfunction is present and it requires a reducer sphincter dysynergy. Simultaneous reducer and urinary sphincter contract produce high pressures in the bladder. In lower motor neuron, the neurogenic bladder, the sacral maturation centers of related peripheral nerves are damaged. The thoracic sympathetic nervous system outflow the uterus. The bladder capacity is large since the reducer zone is low. And the internal urinary sphincter innervation is intact. Despite this, the lower reducer pressure of urinary incontinence occurs. The neuropathic bladder neuropathic incontinence is divided further into failure of bladder storage and function and failure of sphincter function. The loss of reservoir function is due to the poor compliance of the reducer muscle. And minimal bladder filling causes rise in intravesical pressure exceeding the outer resistance and causes urinary leakage. And this solid is present in upper motor neuron lesion and meningeomycete. And strided sphincter activity offering some degree of resistance. It should be managed aggressively. Significant risk to upper tract is present as if the vesical urethral reflex occurs, and renal deterioration and lower urethral disc obstruction can be caused by this failure of bladder storage function. In the bladder storage function, failure of bladder storage function, and immediate catheterization should be failure of sphincter function. Complete lesion of the sacral cord may result in total loss of smooth and strided sphincter activity. The external sphincter offers minimal resistance. Some patients experience such failure can retain some volume. The bladder musculature becomes atonic and intravesical pressure remains low. Any pressure in intravesical pressure can cause leakage. The bladder never reaches full capacity. Consequently, the integrity of the urinary tract is not endangered as in case of reservoir failure. The diagnostic approach is the aim of the diagnostic approach should be to rule out the reducer or sphincteric dysfunction or to see for the combination of two. And it starts with urological and neurological history, physical examination, in ultrasound with for renal size, identifying the scarring, calculi, hydronephrosis, obstruction, and the vesical reflex. Advanced radiological studies including widening cystoureography, excretory urography, and CT scan MRI. And neurological studies, electromyography, evoke potentials. Dynamics include systometry, urethral pressure recording, and flow rate. It is difficult to diagnose, and it needs a multidisciplinary approach, including the neurologist and the urologist. The management includes is always of the neurogenic urinary incontinence is always challenging, and it can be divided into two aspects: treating the pathophysiology behind. The failure of storage in which the first line is anticoagulating agents, selective M3 receptor antagonists. Second line are propalkyl bromide and imiperamine hydrochloride. And then third is the alternative, which is Boston toxin as discussed before, and giving intra and vesicle. Sphincteric dysfunction. CIC is the first line therapy, and balloon therapy have been proven unsuccessful to the date. These are some of the surgical options present with us for. Sir.
No, no, please continue.
Uh, these are the surgical options present for neuropathic urinary incontinence, such as sphincterotomy. It can be done in male patient which has spastic hyperreflexia, and it can eliminate outer resistance. But we have to use external condom catheter post-op. Another option is bladder augmentation, in which the poor bladder compliance can be augmented and improves reservoir function. Artificial urinary sphincter, as discussed earlier, in severe sphincteric damage and low pressure, large capacity bladers. Incontinent urinary diversion, deteriorating upper urinary tract function. Neurostimulation, reducer overactivity, can be used in reducer overactivity. Stimulation of second roots can be used to suppress the overactive reducer. Dorsal rhizotomy. In this, the complete dorsal rhizotomy offers S2 to S4 extra and intradural effectively eliminates the reducer hyperflexion and increases bladder capacity. And bladder placement implantation. In which the suprasegmental lesion and the spastic upper motor neuron lesion, bladder placement and implantation are done recently. The post-maturation dribble, it is actually not associated with urethra or urinary bladder. But in OPDs and urology clinics, we mostly experience this symptom or present with post-maturation dribble. It is actually an involuntary leak of urinary immediately after reaching voiding or just with leaving the toilet. It is due to the weakness of the bulbous spontaneous muscle and to completely expel the urine. Urine pools in the bulbar urethra. Treatment includes pelvic floor exercises and urethra milking with a manually compress the urethra behind the scrotum after maturation until we completely expel the urine out. And this is for the revision of what we have discussed, which includes history, underlying pathophysiology, and type of incontinence associated. In history, the associated voiding symptoms such as poor intermittent flow, hesitancy, poor maturation, post-maturation people straining to void and spraying of stream is mostly have underlying pathology of bladder outlet obstruction such as BPH, prostate cancer, with the stricture leading to chronic retention. So the voiding symptoms are mostly associated with poor flow incontinence. And the storage symptoms such as pointing to urgent urinary incontinence such as pregnancy, urgency, and urgency. And bladder outflow, sexually idiopathic, reduced activity, and skin pathology are the pathophysiology behind this. And if the urine incontinence is associated with hematuria, dysuria, and pain, and urinary infection, underlying bladder pathology, infection, and cancer stone, and causes the urge incontinence. Post-prostatectomy, transfer to resection of benign diseases and prostate cancer causes damage to the sphincter, urinary sphincters, and sphincter weakness incontinence such as stress incontinence. The same is with the post-pelvic surgeries. Stress incontinence is more predominant. Following pelvic therapy, both urge incontinence and stress incontinence can be present. Neurological indications such as spinal bifida, spinal cord injury, and stroke, and predominantly urge incontinence is present. Other factors include poor mobility, cognitive impairment, and constipation of state, smoking and caffeine, medications such as diuretics and anticholinergics, in which all three types alone and in combination can be there. As we have discussed, it is bit clear that these incontinence are mostly overlapping and proper history examination and the further management should be revised before starting on the management. This is the flow chart for patient presenting with urinary incontinence. To start with history and physical examination, urinary symptom assessment and symptom severity, impact on quality of life, general examination, local available bladder digital examination for BPH and prostate cancer. If the case is complicated, such as pelvic irradiation, pelvic surgery, overflow incontinence, associated hematuria, pain, and recurrent UTI, further investigations are required and specialized center and the urologist and senior urologist should be taken on board. Uncomplicated, none of the condition reported on point 3 as we discussed. Simple baseline investigation which includes urine analysis, urine microscopy, frequency charts, bladder scanner, post-maturation residual measurement or ultrasonography. And we can differentiate between sphincter weakness and incontinence, urgent incontinence, and post-maturation paper. And then the management is conservative management and pelvic floor exercises and use of pelvic blockers in urgent incontinence. And in post-maturation people, we can have pelvic exercises and usual breathing. If all these efforts fail, then we have to go for further investigations and surgical and definitely treatment. Thank you.
Excellent. Good. So if I want to summarize the whole topic, this is not one topic. These are three topics which were actually done on 3 days, day before yesterday and a day before also. So it started with the understanding of urodynamics, then we moved on to female incontinence, and then today the male incontinence. All these three topics are actually related to one another. Now, my impression is there are only two kind of urologists, and that you will also see in your days to come. One is the urologist who is interested in the topic of incontinence, and since it is related to urodynamics, then the person is also interested in urodynamics. The other group is who, no matter what you do, they can't understand urodynamics, so they can't understand incontinence process, and they can't treat incontinence properly. So to start with, you are all like 14 individuals. You will be able to judge very soon that in which group you are, whether you are inclined towards understanding urodynamics and then the process of continence and incontinence, or you are not inclined at all, and you will see in the future years, 20, 30 years, that you will be always repelled by this kind of a subject. Why I'm telling you this? Because it takes a lot of imagination. Maybe there is an excitement in understanding the whole pathophysiology behind incontinence. And maybe it is just application of your own personality and personal experiences. Whenever you do clinics, you are in an outpatient clinic. The kind of a specialist that we want to be, we are all urologists. This is a specialty in its own self. But for a urologist, there is always another thing, and that is a subspecialty or a super specialty. And then you are interested in one subject or the other. Maybe you are interested in dealing with urolithiasis, maybe you are interested in oncology, or you are interested in something called incontinence. But you happen to visit and do the whole clinic on Saturday, probably on Monday also. You will see a lot of these cases which are actually having the reflection one way or the other of the continence mechanism, whether it is totally abrupt, disturbed, or it is partly disturbed because of maybe prostatic enlargement, and the person has having age of like 60 years plus. Similarly, if you want to see patients who are female and who are postmenopausal or perimenopausal, they all have got these problems of incontinence. Either they go into retention, they are unable to void, or they have got problem with controlling the stream of urine. Now, the society in which we are, um, again, we are not very communicative. We don't come out very easily from our own selves. Whenever you want to talk to somebody, it doesn't matter whether the person is from a city or he is from or she is from a rural area. Uh, there are always inhibitions in telling something which is very important. But when I want to confide in someone who is a doctor, who is somebody who has got the ability to um, bring some solution to my problem, now that is when the doctor has got the ability or the capability of inducing some kind of confidence. Now, how this confidence comes about, a patient will not tell you something which is as private as having dribbling of urine, soiling of clothes, something which is nasty, something which is obnoxious, something which is not good to speak about. So nobody would tell you anything. So if you are a kind of a person who is not an easy person, from the look of yourself, from the kind of words that you use, from the kind of language that you take, uh, even if you allow me, the movement of your eyes, the gaze which you have, all these things matter. All these things matter. Uh, they matter because what is your intention? Now, if your intention is to do some problem solving work, for instance, if somebody asked me why you want to be a doctor, the simplest of answers would be, I want to be a doctor because I want to help someone. Now, how can I help someone? Maybe I know some procedures. Maybe I know a little bit about some drugs and their interactions and their actions and contraindications and their reactions or whatever. But beyond that, if I want to solve problem, then I must know the problem. So how can I know the problem? I have to have some skills to ask my patient certain questions. I have to have certain mannerisms, what we call, the way I keep myself, the way I conduct myself. All these things matter, and we learn about these things in many years, working in clinics with our patients one by one, or rather one on one. So whenever in a cubicle or in a room we are alone with the patient, now there is actual test of what? Test of personality, test of character. Now it's not about what you are or what you are not. It's about why you want to be at that point in time. So if you want to be a problem solver again, if you want to know, if you want to have that kind of a knowledge from somebody who is an alien, who is a total stranger, and who is a patient, then whole thing will come into play. So this is just a brief sort of a background of why I'm telling you, because no patient will give you a proper history of incontinence, mind you, unless and until you have got something in your character, and that is for sure. So if I analyze the group who doesn't want to go into the details of incontinence, who are repelled, not attracted by the topic of urodynamics, sorry to say, these are the persons who have got no confidence in their patients because they don't see their patients in that sense. I'm not telling you that they are not good doctors. They are brilliant doctors. They can do marvelous surgeries. They are robotic surgeons, perhaps. They can do ablative surgery like no one else, radical prostatectomy, radical cystectomy, or whatever. But a simplest thing as asking a patient, I want to tell you in Urdu कि बीबी आपको पेशाब पे कंट्रोल है, ये जो एक छोटा सा सवाल है, इसके पूछने के बहुत से अंदाज हैं। जब आप पूछ रहे होंगे तो मुमकिन है कि आपकी आंखें उसके चेहरे को देख रही हों, मुमकिन है कि आपकी आंखें जो है वो ज़मीन को देख रही हों, मुमकिन है कि आपकी आंखें जो है वो न जाने कहाँ देख रही हों। ये 3-4 जो आंखों की पोजीशन है, ये उस आंसर पे इफेक्ट करेगा जो कि पेशेंट आपको देगी। मैं यहाँ पे ये आपको बता ही नहीं रहा कि उस पेशेंट का वो क्या है, एज ग्रुप क्या है। हो सकता है वो एक बूढ़ी अम्मा हो सकता है कि एक जवान लड़की हो सकता है कि वो खूबसूरत हो सकता है कि वो खूबसूरत नहीं हो। लेकिन ये जो एक सिंपल सा क्वेश्चन है कि पेशाब जो है वो क्या कपड़ों में निकल जाता है, दिन के किस किस हिस्से में निकलता है, क्या सोते हुए निकलता है, क्या इतना निकल जाता है कि रात को उठ के कपड़े तब्दील करने पड़ते हैं, ये सारे सवालात के जवाबात उस वक्त आएंगे जब आप पहले सवाल को सही तौर पे सही अंदाज से पूछना शुरू करेंगे। और इसमें आपका पूरा कैरेक्टर, पूरा आपका मैनरिज्म्स सारे के सारे जो है टेस्ट हो जाएंगे। आपको खुद अंदाज हो जाएगा कि आप कितने पानी में। आपकी घरेलू तरबियत क्या थी, आपके कॉलेज की तरबियत क्या थी, बहुत सारी बातें मैं इसमें कह सकता हूँ। वो फिर अखलाकियात का और एथिक्स का लेक्चर हो जाएगा। बट कमिंग बैक टू द सेम प्रॉब्लम, if you are interested in the subject, then or if you are not interested in the subject, again, for both these groups of people, you have to study it because this is part of urology. So when you want to study it, you have to study it properly, and the proper way of studying is to understand uh, urodynamics first, then just divide them into male and female incontinence. Both of these conditions do have something in common. There are certain neuropathic disorders, for instance, spinal injury, that can happen in both the cases, in both the genders. But there are certain things which are very important in one gender, and there are certain things which are important in the other gender. For instance, the effect of hormones and the cyclical activity of hormones, because a female is on a 28-day cycle if she is in her reproductive age. In one part of the cycle, estrogen is more as compared to progesterone. On the other part of the cycle, estrogen is less than the progesterone, and these two have got effect on this continence mechanism, and how we'll see later on. Same goes with in a slightly different manner in a male gender. If that person has got an enlarged prostate, having an age of maybe 45, 50 years plus, then the BPH has set in. Maybe the person has got carcinoma of prostate. Maybe you are prescribing some drugs and they have their effects on the continence mechanism. Even if the male gender is of a middle age or probably of a slightly later part of the younger age, meaning to say between 20 and 40. So this is the age group when prostatitis happens. This is the age group when the incidence of prostatitis, particularly acute prostatitis, is more as compared to chronic. Chronic is more in cases of people who have got 50 years or 45 years plus age. So this prostatitis will always have some effect on, again, continence mechanism. So you have to have a lot of thinking to be done, a lot of mental activity. Your last two slides are very important. If you go back to the second last slide or the third last slide, this one. Now this one and the next one, if everybody of you don't just pay any attention to anything that have been discussed in the last two lectures, you just copy or maybe you can just take a picture of this slide and the other one and just paste them on the table or the wall in your room. Just see them again and again. Now this is all that has to be learned about the subject of management of incontinence, right? we can talk about these things in detail in the second round also. For instance, the concept of neurourology and the subject of neurourology plus neuropathic disorders will be taken by uh, I think Mohsen. The second will be the non-surgical management of incontinence, and that would be by Mehtab. And in the second round, I think Zishan would do the surgical management of incontinence, and this would be
Okay.
from EAU guidelines, right?
Okay,
So we would try to do something on a standardized fashion. EAU guidelines are those that have been followed in this part of the world in more um, say commonly as compared to AUA guidelines, the American guidelines, which are followed but not in totality or in commonality in our region, Indo-Pak subcontinent. So this is my take on the subject, and we'll be discussing it, whether you are attracted to the subject or not. But these are the patients, mind you, who need your attention, who need your advice. They will come to the clinic, and I have seen patients who come to the clinic and they don't ask any question, or they don't just say anything to the doctor. They just go away. Why? Because they don't feel that they have got a confidence in the person who has just standing in front of them. So whenever they feel confident, they will tell you a lot, and that is the key factor behind anything called classification of incontinence. And when you do classify them, then the treatment is all standardized. So if anyone wants to say anything, wants to add or ask me any question, the forum is open. जी sir. जी शेषा.
Assalamualaikum.
Assalamualaikum.
Sir, how much filling of bladder is required for it to become overflow?
Again, if it's a normal bladder, we were discussing this topic, I think yesterday or day before yesterday. The first sensation of bladder filling comes on between 150 to 250 ml of bladder filling. The second sensation arises around 350, and the third one at which you will not be able to postpone your act of micturition, that will be beyond 350 at any point, but that is normal. If your bladder is not normal, meaning to say that there is some neuropathic disorder, or there is something which is causing say abnormality in either storage or evacuation of the bladder, then these 3 points, first sensation, second and third, will not be at proper volumes. They would be slightly shifted. For instance, if there is a low motor neuron lesion, something happens to the sacral segments of a spinal cord, then the bladder would be flaccid, which means that bladder will be filled up. Maybe it will go up to the level of umbilicus, and the person will not feel anything at all. What the person will feel is just a bulge at the lower abdomen, a hypogastrium, nothing else. Sometimes what happens is when the bladder is filled up, there is irritation of the parietal peritoneum, and that irritation causes the person to understand that actually the bladder is filled up. But you see, the parasympathetics and sympathetics have to play in consonance. They have to play hand in hand. If you have got some defect at any level between these two autonomic components, you will have a lot of difficulty, right? So that answers your question?
Yes.
Okay. So anyone else?
And sir, in overflow bladder, Dr. Zishan said that milking of urethra behind the scrotum is necessary. So is it the reason between the intestine scrotum, or?
Uh, it's not behind the scrotum. What happens is it is not something which is suggested. It is not something which is scientific that you ask your patient to milk urine out so that there is no dribbling. What we normally do tell them when they have got post-maturation dribbling is to wait for a moment if they can, but if it is exhaustive, meaning to say if the person is not able to sit down in a squatting position, which normally we do in our culture, in our society, if the person is able to sit on a commode for a long time, then he must wait for those few drops of urine to come out. If that is not possible and still this point of dribbling happens, then we ask the patient to do um, micturition in 2 acts. So you double micturate. Once you micturate and then you come out, maybe half an hour or 15 minutes after you go to the toilet again, sit on the commode, do another act of micturation. So in that way, you can train your bladder to micturate properly. Milking of urine is not something which is suggested, but normally people do that thing. But I don't think this is something which is part of our protocol.
I have a question.
Yes.
So in the risk factor, he has mentioned that less intake of fluid is also a risk factor for urinary incontinence. How is it?
Less amount of urine, less amount of water intake.
Fluid, yes, sir.
So Zishan, if you go back to the slide, I don't know whether it is written in that way. Risk factors: immobility, delirium, low fluid intake is a risk factor for incontinence. I don't think so. That doesn't go with what we have. For instance, again, on a flip side, if you have got a lot of fluid intake, that again doesn't cause incontinence at all. There are certain things. For instance, caffeine. Caffeine. If you have got a lot of caffeine, again, you go to the toilet again and again. That is something different. But a low fluid intake, I don't think that this is something which is of importance. So maybe you can strike this thing off from the table or the list.
Okay, thank you.
Right.
So actually, from where I took it from an article, they mentioned it that it is due to low intake of fluid, which causes the frequent infections and infections in the cystitis related to something like that.
Maybe, or maybe not. But you see, for instance, in this list, what is more important if we want to consider the normal or the modern city-dwelling life is morbid obesity. Now, why morbid obesity is too important? Just because of the fact that it goes with another thing which we call as metabolic syndrome. Now, when there is morbid obesity, there is always metabolic syndrome, and that is hyperlipidemia, hypercholesterolemia, hypertension, something which goes with abnormal metabolism of lipids as well as certain other things. And these patients who are on the other end of the spectrum, difficulty in maintaining their body habitus, meaning to say that their weight is much according to the height what they have, then they have got a lot of problems, and one of them is incontinence. And there is a recent article in Journal of Urology also, and they have done on a bigger scale, which means that on a randomized controlled trial, considering a lot of institutions in that trial, and they have seen that just by addressing the problem of body weight and keeping the lipid level to normal, the continence becomes proper, meaning to say that their incontinence, which is because of the fact that there are many players in it, and one of them is the tone of the pelvic muscle. It becomes better uh, when the weight of the patient slightly comes to the normal level. So, but it depends upon person to person, and the obesity, which we call morbid obesity, if it is manifested, if you address this problem, then the problem of incontinence becomes automatically addressed. So this is a very interesting aspect of this disease. Right. So I think we call it a day today also, and meet you tomorrow again. We have got 3-4 lectures left, and then we'll discuss the whole thing, how our experience of 14 different lectures actually um, interest you, help you in understanding urology, or the exercise is not up to the mark. So we'll discuss our at the end of these 14 lectures. I think the 15th lecture presentation would be by Dr. Noman, because this is something which has been added to the list. He is a little bit senior than you, and he will talk on his own topic, and that is testicular cancer, on Saturday. So Noman, if you are listening, you are on for Saturday.
Yes, sir.
Right. So then we have a discussion on, I think, Thursday. And I want everybody of you to just give your feedback, how your experience of these lectures and presentations actually they have got any impact on you, on your understanding of the subject or not. So I want sincere sort of suggestion from your side. Right? Right. Thank you very much. Dafis.